This will be delivered by Dr. Induyudi Gunawardena, Registrar in Community Medicine, Image Office, number 2. This time from Sri Lanka. Dr. Gunawardena.
Good afternoon, dear Chairperson and dear all. At the 138th session of WHO Executive Board, it was stated an integrated people-centered approach is crucial to the development of health systems that can respond to emerging and varied health challenges. While keep that in mind, let me present a case study on antenatal detection of leprosy in primary gravida and a family cluster at MOH Moratuwa. I will take you through this format, my case scenario. Sri Lanka has, as well known, pockets including Colombo district, leprosy pockets, including Moratuwa MOH area and some certain MOH areas. Community stigma still limits timely care and detection of these cases, these patients. At the same time, Sri Lanka is having a very strong public health sector, public preventive health care system, which provides maternal and child health care, especially antenatal health care services with shared care. In that background, I am presenting this case, which pregnancy detection of leprosy and family cluster and stigma-driven refusal, finding solutions to gaps that which we have identified. The figure 1 and figure 2 shows the area of the case community reported, the index case reported community and the area map. So the clinical pathway of this case is 19-year-old primary patient presented to the antenatal clinic at 27 weeks of gestation, and AMOH has identified hypopigmented patches in face, upper lip, and some in the abdomen. And we have, from the MOH, we have referred the patient to the Colombo South Teaching Hospital Dermatological Clinic, where the leprosy was diagnosed with skin biopsy. And notification was completed and field investigation also conducted by the MOH team. From the dermatology clinic of Colombo South Teaching Hospital, they have planned the follow-up visit for the start of the treatment following the delivery during the postpartum period. To improve the compliance, from the MOH team has planned for a escorted referral. That means the patient will be accompanied by area PHM to the clinic following the postpartum, during the postpartum period. At the same time, at the household inspection and the at the field investigation, the MOH team has understood that her elder brother was treated for leprosy, but contact tracing was not done, and mother was also having hypopigmented rashes, which probably due to leprosy, but continuously refusing the treatment and clinic visits due to stigma and the inconvenience of the clinic follow-up and specialist clinic entry. So here we have identified retrospectively, following intervention that we have made by the MOH team. One thing is screening for leprosy at the antenatal clinic, and the second one is extra measures planned to ensure the compliance, such as the escorted referral and repeated targeted health education considering the family care. So these are the antenatal notes. Figure 3 shows the pregnancy record, and figure 4 H544 notification which we received, and figure 5 shows the communicable disease investigation report part 1, H411 part 1. So for the retrospective evaluation, we have used process methods and output measures. Timeliness of detection, referral and notification were evaluated, and delivery to postpartum linkage was evaluated, and household counseling and health education attempts were qualitatively evaluated, and acceptance and the confusion of specialist review was also evaluated under process measures at the MOH team, by the MOH team. For the output and outcome measures, index case linkage to therapy during the postpartum period was evaluated, and number of household contacts and persistence of barriers qualitatively evaluated, and actions initiated by the public health team were evaluated, such as the PHI checkup, phone call reminders, and sporadic referrals, like this. All throughout this presentation up to the trial was ethical aspect also considered, and de-identification of reporting and consent, verbal consent was obtained for this presentation from the Z family. So results, at the moment the mother has delivered, leprosy confirmed during the pregnancy, and the planned postpartum visit was arranged, and the dermatological follow-up, first follow-up was already done. At the end of September, she has been delivered, and within the second week of the October, expert referral was done by the area PHM. And family cluster, following repeated health education sessions by the MOH team, and with multidisciplinary approach with the help of religious leaders in the area, the continuous refusal to seek the specialist care was changed to acceptance, but it is still there's a hard work to done, as still the mother only accepted that she needs to get the treatment, but it is not implemented so far. So barriers identified were fear of labeling, as many of the cases, and throughout this conference it was discussed, anticipated community judgment, and apart from that, travel and logistic issues to enter into the tertiary care was difficult even in Colombo district also, which related to this kind of community. And public health response was, there were 2 PHI visits conducted, and phone calls were given, reminders given, and 3 health education sessions were conducted, and 1 referral was conducted. One time clinic visit was there, accompanied by the area PHM. So, as a case study, here what we learned as the MOH team, first thing is ANC clinic is it can be used to find hidden cases, because ANC clinic, antenatal clinic are the mothers who are becoming pregnant, and those who are coming for pregnancy sessions. Antenatal visits are usually happens to these are compulsorily happening within the all the MOHs. So it can be a good basement, it can be a good platform to identify or screen for leprosy and contact tracing also will be possible with this kind of already established healthcare services. as well as after birth, health education towards family care, especially mentioning the newborn, the health of the newborn, considering the health of newborn, the health education, if the health education is more towards the family care, it is also, we have identified through this case, we have identified it is also one of feasible and possible option to change their thinking pattern. So I would like to make practical program fit improvement. One thing is introducing in order to standardize the taking, in order to standardize in leprosy screening, introducing the field pregnancy record for highly prevalent MOHs and arrange regular outreach dermatological clinics for highly prevalent areas. Thank you.
Thank you for showing us different aspects of disease management. I have one point to show here. So I think we should change our practice. Why don't we advise other health staff to just look for two things in leprosy, to diagnose it, to suspect leprosy, not to diagnose, just unexplained numbness and unexplained hyperpigment at everything, at every medical clinic, medical, surgical, in and out. It don't take a lot of time, suspect and refer to the dermatologist. I think we may be able to diagnose a lot of cases. Each and every medical, surgical, gynae and pediatrics, just two things. Unexplained numbness and unexplained hyperpigmented cells. Not to diagnose leprosy, suspect leprosy and refer. We can diagnose. You can take it.
Our third presenter in this session